Suraj Tiwari, welcome you all to this novel educational initiative of Mumbai Hematology Group, a webinar on new WHO classifications of lymphoma. We are grateful to Dr. M.B. Agrawal sir for such educational events. He is a renowned figure in hemato-oncology and institution himself, and we are fortunate to have him because he has enriched us with by collaborating with many stalwarts in hematology. So today we have Dr. Amit Khurana sir, who is a moderator for the event. Dr. Amit Khurana is a highly skilled and experienced hemato-oncologist with decade of experience in the field. He is experienced in performing bone marrow aspiration, bone marrow biopsy, and other hematological procedures. He has extensive experience in both autologous and allogeneic stem cell transplant. So, sir, over to you for further proceeding of the meeting, sir.
Thank you, Mr. Suresh. So very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Professor Dr. Naresh Kikari from Fred Hutch, Seattle, Washington, USA. And he's going to lecture us on new WHO classification of lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Professor Dr. Naresh Kikari from Fred Hutch, Seattle, Washington, USA. All our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 21st of January 2024, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on an update on aplastic anemia, non-transplant management by our guest speaker, Dr. Austin G. Kulasekara Raj from King's College Hospital, London, UK. Now it's a time to introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Anju Bharti from Banaras Hindu University, Varanasi. Dr. Ankur Ahuja from AFMC, Pune. Dr. Chitra Madivale from PD Hinduja Hospital and Medical Research Center, Mumbai. Dr. Debadita Ray from MedGenome, Bengaluru. Dr. Devdutt Basu from Jipmar, Pondicherry. Dr. Deepak MB from MSMC Narayan Health City, Bengaluru. Dr. Durga Devi S from Manipal Hospital, Bengaluru. Dr. Neen Mia Thanda from North Okkalappa General Hospital, Myanmar. Dr. K. Gayatri from Lifeline Tapadia Diagnostic Center, Hyderabad. Dr. Manu Vimla Chandra from University of Colombo, Sri Lanka. Dr. Myat Mallar Sway from Medley, Myanmar. Dr. Neeraj Arora from Uniped Specialty Laboratory, Ahmedabad. Dr. Om Shri A. Shetty from Tata Memorial Hospital, Parel, Mumbai. Dr. Rakhi Kar from Jipmar, Pondicherry. Lieutenant Colonel Dr. Rama Hariharan from Kaman Hospital, Lucknow. Dr. Rima Media Abraham from Amrita Institute of Medical Sciences, Kochi, Kerala. Colonel Dr. S. Venkatesan from Armed Force Medical College, Pune. Dr. Sanjeev Kumar Gupta from AIIMS, New Delhi. Dr. Sanjeeva Pathirage from NHSL, Colombo, Sri Lanka. Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida. Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Dr. Sheila Nair from Nehruvi Hospitals, Vellore. Dr. Shivani Joshi from Nasik Hematology Services and Mumbai Onco Care Center, Nashik. Dr. Subhangi Agale from Grant Medical College, Mumbai. Dr. Sindhura Lakshmi KL from Manipal Academy of Higher Education, Manipal. Dr. Sumit Gujral from Tata Memorial Hospital, Parel, Mumbai. Dr. Tanuja Sheth from Tata Memorial Hospital, Parel, Mumbai. Brigadier Dr. Tathagat Chatterjee from Faridabad, Haryana. Dr. Thamodika P. Vithanage from Base Hospital, Panadura, Sri Lanka. Dr. Tushar Sehgal from AIIMS, Delhi. Dr. Udyan Khachi from Vadodara, Gujarat. Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center, Mumbai. Dr. Vijay Tilak from BHU Varanasi, Dr. Yenifa Samaravira from Colombo, Sri Lanka, Dr. Yimon Tan from Yangon, Myanmar. Now it's the time to introduce our guest speaker for the day. We all know him very well. We have with us Professor Dr. Naresh Kikari from Fred Hutch, Seattle, Washington, USA. Professor Dr. Naresh Kikari is hematopathologist with focus on lymphomas, bone marrow pathology, and molecular pathology. He has been in the field of hematopathology for over 30 years. He has worked and trained across 3 continents, namely North America, Europe, and Asia. Prior to joining Fred Hutchinson Cancer Research Center, Seattle, Washington, the US, he was been at Hammersmith Hospital, Imperial College London, UK. He leads the diagnostics, translational research, and training in hematopathology. He was a chair of the British Lymphoma Web Pathology Group, that is BLPG. As a part of his activities in BLPG and Royal College of Pathologists, he played a very critical role in improving standards of training and practice of hematopathology in UK. He has over 250 publications, majority of which are in the field of hematopathology. In hematopathology research, his collaborations extend with investigators and institutions in United States, Europe, Asia, and Africa. He is a firm believer in global medicine and science and in fostering international collaboration to promote translational research and training in hematopathology and in other branches of medicine. And today he's with us and he's going to update us on new WHO classification of lymphomas. Well, thank you so much. Over to you, Professor Dr. Naresh Kikari.
Thank you. Thanks for that fantastic introduction. I hope I will live up to those expectations. That makes me a bit scared. Let me just want to make sure it is seen in the right mode.
Yes, sir. We can see your slides.
Okay. Is it in the presentation mode?
Yes, sir. Yes, sir. Perfect. Please proceed, sir.
Okay. I'm grateful to Dr. Agarwal for inviting me again. And it's wonderful to see how Dr. Agarwal has continued to do his educational activities with such great zeal. Way back from my days in Bombay, Mumbai, I had seen Dr. Agarwal, conducting these meetings, and I think his zeal has never dampened over all these years. And when I first saw the list of discussants and the long list, it was quite scary. But then when I started looking at the names, it was full of my friends and colleagues and people who I have worked with. It's really a pleasure to to present this to all of you. This is quite a daunting task to talk about the WHO classification and the 5th edition of the classification, which is has already appeared in its online beta version, and we're expecting the blue book to come out in the next few months. And also, it was a great pleasure, responsibility, though a lot of work, to participate in the as an editor of the new classification. It has taken nearly over 2 years of work, but we hope that eventually this will address the needs of people across the world. I work at the Fred Hutchinson Cancer Center in Seattle, which sits on a land. We want to acknowledge the Coast Salish people of this land, and also the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Squamish, and Tulalip and Muckleshot nations. We need to acknowledge all these tribes where our institution sits. Back on the WHO classification, I started my career in lymphomas when the working formulation, many of you may not even have heard about it, was in O. And as a student, I learned that first from Dr. Anita Borges. And that was my first introduction to lymphomas. And then was the period of the real classification, which I had the a fortunate way of learning that directly from Dr. Elaine Jaffe when I was a fellow. And then actually I got used to WHO classification only in its third edition. That was in the early 2000s. And all of us have, at least I have been through three editions of the WHO, the second, the third, the fourth, and the revised fourth edition. And we have seen how the lymphoma classification has been evolving during this period. And now we have, it's just we are at the time when the fifth edition is going to be released soon in the next coming few months. This is the online version of the fifth edition that's currently available. In its beta version, it's soon going to be locked. The final proofs have come to the editors. It's being carefully looked at. So I'm going to talk to you or introduce you to the B cell and T cell lymphomas as it appears in the WHO classification in the next hour or so. As one could imagine, this is a huge, vast field, and it's impossible to capture this in an hour's time. So I'm not going to dwell in depth. I'm going to focus mostly on the general principles of these classifications, the key changes that have happened from the revised fourth edition, the gaps that still exist, what are the challenges that we face, and how do we try to go through these challenges. First of all, this is a hierarchical classification in the sense that there are family names or group names, there's names for specific entities, and then there are subtypes. In an ideal world, one would have to go through, do the complete workup, go all the way up to the subtype. But one has to understand there can be several limitations of the biopsy, limitations of the clinical information that one may have at the time of diagnosis, or simply limitations of the infrastructure under which one is working. So in such situations where one cannot come to a specific entity, one could use the family or the group name to issue a report. There are essential and diagnostic and desirable criteria for diagnosis. And again, this was something which was a very balancing act. We had to write a classification which was scientifically relevant to this day. At the same time, WHO classification is not a classification just for the Western world. It's not a classification just for North America, Europe. It has to be, or at least one should be able to apply that to a reasonable extent across the world. So it's a fairly balancing act, and I will touch upon this as I go through some of these entities. There are many advances that you will see. There are many recent papers which have appeared, which may not have been accommodated in the WHO classification, because overall the classification required not just one good publication, but some validating results as well. So we have tried to make it as much evidence-based as possible, number one. We've also tried to make it as much as from across the world and across disciplines. So people on the authorship of WHO classification have been not just pathologists, but it's been geneticists, it's been medical oncologists, hematological oncologists. So everybody has come together to put this classification. There are a few changes from the past. In the past, it was purely documented and well reproducible malignancies that was seen in the WHO classification. But now we have introduced some tumor-like lesions, like both in the B cell areas and in the T cell areas. Like in the B cell areas, let me go to the next one here. In the B cell areas, you also have, like, we all know the difficulties we face in day-to-day diagnosis. There are many, from a simple florid follicular hyperplasia, which can cause difficulties in diagnosis with follicular lymphoma, or a progressive transformation of germinal center, which can cause difficulties in diagnosis with nodular lymphocyte predominant Hodgkin lymphoma. Those kind of lesions are accommodated. And also there are some evolving entities which are right on the border of neoplasm, like the IgG4 related diseases. We know this is an autoimmune disease, but we also know that it has some overlapping features with some of the neoplasms. And then we have the Castleman disease, which is itself a large number of different types of entities accommodated under the title of Castleman disease. Similarly, within the T cell areas, there are T cell predominant tumor-like lesions, which includes Kikuchi-Fujimoto disease. There are also indolent T lymphoblastic proliferations and autoimmune lymphoproliferative syndrome. I will touch on some of these entities. Castleman disease is known for a long time, and talking about Castleman disease, probably one can spend a couple of hours to discuss this, but for brevity, we know that we broadly classify them as unicentric and multicentric. And unicentric, we also classify them as hyaline vascular and plasma cell rich. And then you have the multicentric Castleman disease, which is now classified into several sub-entities. The idiopathic multicentric Castleman disease is probably what is more frequently seen in India, but areas where you have HIV, particularly outside of India, one often sees HIV-associated, HHV-8 case HV-associated multicentric Castleman disease. I just want to bring up slightly out of context here that though the disease known goes by the name Castleman disease, it's interesting to know that this entity was first described by Edwin Leconte more than 50 years in 1899. And that paper was completely lost and was not even seen by Benjamin Castleman when he described this entity. So Castleman disease is an entity which was recognized more than 100 years back. There are similar tumor-like lesions of T cell predominance. Autoimmune lymphoproliferative syndrome, or ALPS, is an important entity to recognize. It can be caused by either by germline or somatic mutations in the in genes of the FAS pathway. Those where you have a germline mutation, usually patients present in early childhood, and those with somatic mutations, they present later in life. Patients present with lymphadenopathy, hepatosplenomegaly, autoimmune cytopenias, and an increased risk of lymphomas. And usually lymphomas are B-cell lymphomas, and they include classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. The typical morphology is that of a PTGC, or it can have Castleman-like features. And the classic abnormality that one can recognize is the expansion of the double negative alpha beta T cells, either in the lymph node or in peripheral blood by flow cytometry. Indolent T lymphoblastic proliferation it's important to understand, to know this entity and to think of this entity, because traditionally one would have thought that if you see T lymphoblasts outside of the thymus, it's abnormal. But there are several situations where you can see T lymphoblasts, which are non-clonal T lymphoblasts outside of the thymus in nodal or extranodal settings. The typical situation where I encounter this is in the area of Castleman disease, either in idiopathic Castleman disease or in HHV-8-associated Castleman disease. These lymphoblasts, the cases that I have personally seen, they have seen as small clusters, and now it has almost become like any Castleman disease that I see. I tend to do a TDT, and I use this as a feature to recognize Castleman disease or to document, because Castleman disease diagnosis, idiopathic Castleman disease can be difficult, and it can overlap with non-specific reactive aplasias. So I tend to use this feature. And again, a feature that I always apply is to look at LMO2 expression. LMO2 expression is negative in indolent T lymphoblastic proliferations, whereas LMO2 is positive in T lymphoblastic lymphoma or leukemia. And CD34 is negative. But if you see this outside of the situation of Castleman disease, it's important to make sure that it is indolent, follow the patient for at least 6 months, and make sure that there is no bone marrow disease or mediastinal disease at the time of presentation. Chaitra sent me an email that I should discuss this, and I thought I tried to borrow a slide from my colleague Suyan Chen on a more characteristic case than what I have seen myself. Here is a case of Castleman disease, where you can see typical Castleman vascular type follicles, and then you see large number of CD3 and TDT positive lymphoblasts in the background. Similarly, you can recognize this by flow cytometry, where you can see here this is this is shown in contrast to a case of T lymphoblastic lymphoma, leukemia. And here is the small number of T cells which are positive for TDT and CD1A and double negative for CD4 and CD8 here. So when we look at, there are a few other changes in the new classification, where we have moved from lymphoproliferative disorder to lymphoma. One of those is the chronic lymphoproliferative disorder of NK cells, which is now labeled NK large granular lymphocyte leukemia because of its biology. In contrast to that, the primary cutaneous active CD8 positive T cell lymphoma, which which went by the a lymphoma connotation in the revised 4th edition, is now downgraded to a lymphoproliferative disorder because of its extremely indolent behavior. Other changes in the lymphoblastic leukemia lymphoma is a very large area which I'm not going to touch upon today. Genetics and specific abnormalities form an important part of the diagnosis, and there are 2 new specific genetic abnormalities which have been introduced in the classification of lymphoblastic B lymphoblastic lymphoma. And what used to be called NK lymphoblastic leukemia lymphoma has been excluded because of the difficulties in diagnosis of this condition and lack of reproducibility. There are some other changes in the small B-cell lymphoid proliferation, which are fairly frequent. I think I'm going to discuss at some length on these. One of them is in the revised 4th edition, there was an entity called atypical CLL type monoclonal B-cell lymphocytosis. Again, this is an entity which is not really reproducible, and that has been deleted. More important deletions from the revised 4th edition are a B-cell prolymphocytic leukemia and hairy cell leukemia variant, which we will discuss. Another minor change is the testicular follicular lymphoma, which was identified as a distinct subtype of follicular lymphoma in the revised 4th edition, has not been stressed to the same extent and is not recognized as a distinct entity within the follicular lymphoma, a distinct subtype of follicular lymphoma. Because what we have seen is, though testicular follicular lymphoma occur in the pediatric age group, the same can also occur in adults, and there is no, it's not biologically, and again, they tend to do quite well, but there is still a huge overlap with the adult follicular lymphoma, and I think more studies are required to to ascertain that this is a distinct entity. So in the current classification, it does not come out as a distinct entity, but again, more studies are required if we were to properly categorize this as a separate subtype of follicular lymphoma. As I said, B prolymphocytic leukemia has been excluded. The reasons for this is even in the revised 4th edition of the WHO classification, we had recognized at that time that blastoid variants of mantle cell lymphoma can morphologically look similar to a prolymphocytic leukemia. So that had already been excluded. But then the criteria of proliferative leukemia in the revised fourth edition was dependent on identification of 55% of prolymphocytes in the peripheral blood. As one can imagine, any kind of numerical criteria like 55% is a very arbitrary number. Would the biology of a disease which is 50% prolymphocytes be different from that with 60% prolymphocytes? And how reproducible is a prolymphocyte count? So all these issues come into play. And then when you look at these cases, many of them may have the telltale signs of other indolent B-cell lymphomas. Many of them may have features of a chronic lymphocytic leukemia. So many of these could actually be transformed leukemic forms of other indolent B-cell lymphoma leukemias, and thereby B proliferative leukemia has been excluded in the current classification. Those which are CD5 positive and those once you've excluded mantle cell lymphoma, what used to be CD5 positive BPLL are recognized now as prolymphocytic progression of CLL. Remember, in the earlier classification, those cases which had more than 15% prolymphocytes was already recognized as a progression of CLL. And then the distinction was done at the cutoff of 55%. So currently, if it is CD5 positive, it has more than 55% prolymphocytes, irrespective of the number of prolymphocytes, they're all categorized as prolymphocytic progression of CLL. Then you also have CD5 negative forms of prolymphocytic, what used to be called PLL. Those have been accommodated under a category as splenic B-cell lymphoma with prominent nucleoli. We will come to it in a second. So BPLL in the earlier version, as I said, was an entity with more than 55% prolymphocytes. It typically had a complex karyotype with many translocations and had frequent abnormalities of the MYC path of the MYC gene of TP53, like deletion 17p or TP53 mutation. Again, indicating that this is some form of transformed lymphoma. And in the CD5 positive non-mantle cell BPLL had many features, genetic features reminiscent of a CLL, PLL, which has undergone progression. So if it is CD5 positive, it could be mantle cell blastoid, or it could be prolymphocytic transformation of CLL, SLL. And those which are CD5 negative, it goes into a term splenic B-cell lymphoma leukemia with prominent nucleoli. The key features that one has to recognize in a CLL has been stressed, which was also already there in the previous classification, but there are some new information that have been added in the fifth edition. The FISH or cytogenetics to recognize the common abnormalities, prognostic, which has prognostic connotations is important. TP53 mutation analysis is quite an important thing to do in CLL. Similarly, looking at the mutation pattern, the somatic mutations in the immunoglobulin V region sequences is key. Also recognizing the B-cell receptor stereotype subset analysis, and particularly recognizing the subset 2 configuration is another important feature. And then chorotypic complexity is a very important prognostic feature. There are other things which are coming to light, is the mutations in BTK, PLCG2, and BCL2 status. I will come to this in a minute. Because many of these patients get inhibitors of the BTK or inhibitors of BCL2, I think knowing the status up front is quite important. So how do we define, now within CLL, we have something what we call an accelerated CLL, SLL, or histologically aggressive CLL, SLL, or prolymphocytic progression. If one is looking at peripheral blood, use the term prolymphocytic progression. If one is looking at tissue sample, use the term histologically aggressive CLL or SLL. The histologically aggressive CLL, SLL has large unconfluent proliferation centers which occupy more than a 20x field. And the proliferation index is high. It has more than 2.4 mitosis per proliferation center, or the Ki67 is more than 40%. And the outcome of recognizing this as a distinct form, different from Richter transformation, is important because the clinical outcome of these patients is somewhere intermediate between typical CLL and the Richter transformation. And prolymphocytic progression, the term that you use if there are more than 15% prolymphocytes in the peripheral blood, irrespective of the upper limit of the prolymphocytes. Here is an example of what one would call an accelerated CLL. And in peripheral blood, you can see there are atypical cells and the cell size somewhat similar to that of a neutrophil. They have a prominent a nucleolus, many of them, and these are not typical CLL cells. And the same patient's bone marrow look like this, the hypercellular marrow. You can see even in this magnification, there are areas with more smaller cells, and there are areas where you have larger lymphoid cells. And here is an area with more small lymphoid cells, the heavily treated patients. So you can also recognize some abnormalities in erythroid and megakaryocytic lineages, but the lymphoid infiltrate here you can see in this field, most of them have features of typical CLL. But when you look at other sites and you start seeing more large cells, but there are scattered large cells in within areas with small lymphoid cells. And here is an area where there are more large cells, but you can see a whole range of cell size of these abnormal lymphoid cells. But most of the lymphoid cells here have a small nucleolus. And here's a CD20. You can see these large lymphoid cells in the background of small lymphocytes. And then here's CD5 positive. CD23 is overexpressed in these larger cells. They're LEF1 positive. And some of these cells can also express cyclin D1, like in the lymph node with cases which have got prominent proliferation centers, a subset of cells can express cyclin D1. Here in the bone marrow, you can see these cells expressing cyclin D1. And this was a well-known CLL. There was no 11-14 translocation. And this is a good example of an accelerated type of CLL. If the large lymphoid cells were seen in sheets, one would have called this Richter transformation and treated the patient accordingly. These are the four entities that one has to remember when one thinks of histologic transformation of CLL. SLL, one is true Richter transformation, which can be of diffuse large B-cell lymphoma type or the classic Hodgkin lymphoma type. Then rarely you can get what's transdifferentiation, is where the tumor assumes a histiocytic dendritic cell neoplasm characteristics. Then you also get cases of CLL where you have scattered HRS cells and HRS-like cells. There is current literature coming, one large study which has shown that cases with HRS-like cells should be called Richter transformation. And these patients are treated, if the Richter transformation of classic Hodgkin lymphoma type is treated on classic Hodgkin lymphoma protocols. So the question that comes is, if you start seeing occasional HRS-like cell, should that be called a Richter transformation of Hodgkin type and treated with Hodgkin lymphoma protocols? WHO has taken a more conservative approach, and these such entities where you have scattered HRS-like cells without the complete milieu of Hodgkin's are currently not categorized as Richter transformation. We will have to wait for some time to see whether there will be increasing evidence that these patients will benefit from Hodgkin lymphoma-like treatment to make any further changes to the classification. So one should also be careful about pseudo-Richter transformation, which occurs in patients who are on BTK inhibitors and where the BTK inhibitor is withdrawn. This is truly an important entity to recognize, and I will show you an example. This is a case of CLL, just to go on the previous point. Here is a patient with CLL where you can see occasional large cells. And these cells have features of mononuclear Hodgkin cells. And here you can see these have got all the phenotypic features of classic Hodgkin lymphoma. These cells are CD30 positive, CD15 positive, PAX5 is weak, and all these cells are CLL cells, and you can see the cells immediately rosetting these PAX5 weakly positive cells are not B cells, they are T cells. And then, of course, these also overexpress MYC. So as of now, in the WHO classification, this would not be categorized as a Richter transformation. This would be called classic Hodgkin lymphoma with scattered Reed-Sternberg-like cells. But some people believe that such cases should be classified as Richter transformation. So that's an area which is evolving, and we got to see how the evidence evolves. Here's another case which I want to bring to your notice. This was a patient, long-standing CLL, who was undergoing pelvic surgery. So the BTK inhibitor, ibrutinib, was stopped for a week before the surgery. And at the surgery, they picked up a few lymph nodes, and the lymph nodes showed features like this. It looked like a Richter transformation. At the time when the lymph node was being evaluated, we did not know the patient was on BTK inhibitors, which had been temporarily withdrawn. Luckily, it came to the attention of the hematopathologist, and because the lymph node was relatively small, patient's LDH was not high. Patient's PET scan did not show any large lymph nodes or anything to indicate disease progression. Then we went back to the history of this patient to see that, okay, a week back, patient's ibrutinib had been stopped, and then we made the right call of saying that this is not a Richter transformation, and eventually patient was restarted on ibrutinib, and everything, and patient has been fine. So as you can see, these areas show strong MUM1 expression in these large cells, and Ki67 is extremely high. So by every parameter, it can be easily mistaken for a Richter transformation. And they often start expressing light chains. You can easily demonstrate there is a light chain restriction, and it maintains many other immunophenotypic features of CLL. CD5 is still weakly positive. LEF1 is quite strongly positive. One important feature to distinguish from a true Richter transformation is that a PD1 is not expressed by these cells. There have been several reports which indicate that PD1 as a good marker to recognize a Richter transformation. So true Richter transformation, you will see sheets of large B cells, and usually they have a non-GCB phenotype, and PD1 is often positive. CD5 can be occasionally positive, and most cases are EBV negative. Then I want to come to the next issue about this splenic B-cell lymphoma leukemia with prominent nucleoli. This, as I said, is a placeholder. This is not a specific entity. We introduced this term just to bring together cases which don't really fit into what was described before. And here you see peripheral blood with medium to large atypical lymphoid cells with abundant basophilic or pale cytoplasm, and some may have projections, and typically these cells have a large prominent nucleolus. And bone marrow may show interstitial or intrasinusoidal infiltrates of these atypical B cells. And if one were to get splenectomy specimen, that could show diffuse red pulp involvement and intrasinusoidal infiltrates. Here's the typical example where you can see peripheral blood with relatively large lymphoid cells, and these have abundant pale basophilic cytoplasm, the prominent nucleolus in these cells. And here's the bone marrow, which is showing a more diffuse involvement of these medium to large size lymphoid cells, which are CD20 positive, and they express IgM and IgD. So based on the expression of IgM, IgD, one might think, oh, this could be a splenic marginal zone lymphoma, but the morphological features in the peripheral blood and the bone marrow look atypical for a regular splenic marginal zone lymphoma. by the presence of these prominent nucleoli. So this would be a good case, which would now be categorized as splenic B-cell lymphoma leukemia with prominent nucleolus. So as we understand now, all the entities which were called as hairy cell leukemia variant now would come into this was, as it is a vanishing entity. There was hardly in the last uh, 3 years in my stay here at the Frederickson Cancer Center, I hardly made a diagnosis of a hairy cell leukemia variant. And then you had CD5 negative BPLL, which would now come into this category. Also, there would be cases like the one which I showed you, what used to be classified as a splenic marginal zone lymphoma, but had high-grade features, more aggressive features, would be categorized as splenic B-cell lymphoma leukemia with prominent nucleolus. Again, one has to remember distinction of splenic marginal zone lymphoma from splenic diffuse red pill B-cell lymphoma was always difficult on peripheral blood or bone marrow, and this distinction was made only in the in splenectomy specimens. But there could also be a subset of a splenic diffuse red pill B-cell lymphoma where the cells have aggressive features, and that would also come into splenic B-cell lymphoma leukemia with prominent nucleolus. This looks like an entity which is a conglomeration of other leukemias which have undergone progression-related events resulting into possessing more aggressive morphological features. So this is a summary of the changes that we are current in the fifth edition of the WHO classification. There are certain very distinct entities like hairy cell leukemia. It remains as hairy cell leukemia. It's a very distinct entity with a distinct genotype. Then splenic marginal zone lymphoma, a subset of them, as I said, like the case I showed you, would now be characterized as splenic B-cell lymphoma leukemia with prominent nucleolus. Then you have all of the hairy cell leukemia variant, which we all of the hairy cell leukemia variant would now be categorized as splenic B-cell lymphoma leukemia with prominent nucleolus. Then a small subset of the splenic B-cell diffuse red pill B-cell lymphoma would also be recategorized as splenic B-cell lymphoma leukemia with prominent nucleolus. Then BPLL is an entity which has disappeared. So some of them, as in the fourth edition, would be a mantle cell lymphoma. Some of them would be prolymphocytic progression of CLL, and some would go into this placeholder category of splenic B-cell leukemia lymphoma with prominent nucleolus. And CLL with more than 15% prolymphocytes would go into prolymphocytic progression of CLL. There are some, not too many changes. There are minor changes in the marginal zone lymphoma category. We now understand that the pediatric type nodal marginal zone lymphoma has some overlapping features with pediatric type follicular lymphomas, and one would advocate doing a wider workup for the Germinal Center immunophenotype to make sure that this overlap between pediatric type follicular lymphoma and nodal marginal zone lymphoma is addressed, and also to one would encourage people to do more mutation studies, which I will come into in a minute when I discuss follicular lymphomas, to make those distinctions. We also recognize that particularly with primary cutaneous marginal zone lymphoma, there are two types. One is the heavy chain class switch type, where you have the heavy chain expression is of IgG, IgA, or IgE, which is a predominant type. And these have a much more indolent course, whereas the non-class switch IgM positive type has a more aggressive course. Just again to reiterate these two subtypes, again, about 20 to 40% of the cases are IgG4 positive. So again, one has to be careful not to miss these cases of IgG4 related disease, but these are light chain restricted. And there are a large number of T cells. T cells can be so much that it can obscure the B cells. And also some of these entities if one misses the B cells in the background, one could mistake this for a plasma cell neoplasm, because the monotypic plasma cells, which are at the periphery of the lymphoid cells, can be quite prominent, and it can be easily mistaken for a plasma cell neoplasm. Whereas in the non-class switch form, there are fewer T cells, and the plasma cells are also fewer, and they are scattered amidst the B cells. Well, there is some disturbance in the background. I don't know whether I'm. Okay, thank you. Tradition. Okay, now we move on to follicular lymphoma, where there has been significant changes. The revised fourth edition, in the previous edition, we classified follicular lymphoma into three grades: grade 1 to 2, grade 3A, and grade 3B. Even then, we had recognized the distinction of grade 1 and 2 is not relevant. And then we had also diffuse follicular lymphoma variant, and then testicular follicular lymphoma. So the question has been that, is grading of follicular lymphoma relevant? Even if we were to think grade 3B follicular lymphoma as something distinct, many publications have questioned whether distinction of grade 1, 2 from grade 3A follicular lymphoma, is it really relevant? And the new WHO classification tends to believe that it has made the grading optional, thereby and there are many reasons which I will go into why the grading was made optional, but is it biologically relevant? That's an important question to address. While the WHO classification was being formulated, from our group, we tried to address this question looking at the SEER database, or the patients in the SEER database. There are a large cohort of patients. These are all patients following 2005, when the rituximab was introduced uniformly in patients of follicular lymphoma. And we do see, and again, this is not, none of these diagnoses have been vetted by a single person or any expert. These are seen by thousands of different pathologists or hematopathologists across the US. And looking at close to 20,000 patients, you can see that there is a difference in survival between follicular lymphoma grade 1, 2, and grade 3. But in the SEER database, there is a problem that grade 3A and grade 3B are not separately categorized. So they are clubbed together, making it more difficult to come to conclusions. But between grade 3 and grade 1, 2, there is a small but significant difference. But when we also, I'm just showing you one survival graph here, but we looked at patients with higher stage, patients with B symptoms, and these graphs widen. There is a much bigger difference between grade 3 and grade 1, 2 in patients with B symptoms or patients who have stage 3, stage 4 disease. Subsequent to our publication, there was another study which came from China, where they specifically looked at this question of grade 1, 2 versus grade 3A, and there seems to be a difference between grade 1, 2, and grade 3A. So what are the issues in grading? One is, as recognized in the revised fourth edition, we can't see any differences in outcome between grade 1, 2. Even in our data study, which we did on the huge SEER database, we did not see any difference between grade 1 and 2. And there are many other studies, relatively smaller studies, which have not documented difference in survival between grade 1, 2, and grade 3A. And I think the only study, which is a large study with clear differences there, was the Chinese study. Before that, there was a study from this WOG, where there was a difference but was not statistically significant. And there are many other practical problems. The distinction of centroblasts from centrocytes and distinction of centrocytes from reactive T cells and morphology can be quite difficult. Quality of the sections come into play, and inter-observer and intra-observer reproducibility is quite poor. And there is no standardized way of how we define a hypover field, because grading was dependent on counting the number of centroblasts per hypover field, and there is no standardized hypover field. And in the same biopsy, one can see different grades. You can have follicles of grade 1, 2, which are 50%, and then maybe other 50% of grade 3A, or even sometimes even grade 3B. And then when you have a small needle core biopsy, how relevant would the grading be? So these are all the questions, these are all the challenges that one has to face. So how do we address these challenges? One, if there is no differences, can we bring up some more simpler grading system? Then if the recognition of centroblasts, centrocytes are difficult, can we come up with a biomarker which will recognize centroblasts and centrocyte differently? If a high power field of a microscope is not good enough, not standardized enough, can we come to express these cells per unit area using digital pathology? If we have got coexisting multiple grades, can we move into completely new biomarkers which will look at progression of disease in 24 months or part 24, which is a marker for histological transformation? And then can we mandate doing larger biopsies in these patients? Well, these are all plausible solutions, but again, a lot of work needs to go into this. So the current WHO classification has taken a slightly different route of coming up with 4 categories. One is what we call a classic follicular lymphoma. Then we have follicular large B-cell lymphoma, which is typically like what used to be follicular grade 3B. Then we have 2 categories, what we call follicular lymphoma with unusual cytologic features. A subset of these have blastoid chromatin, and a subset of these have got unusual, like large centrocyte-like features. And then we have a category of follicular lymphoma with just predominantly a diffuse growth pattern. Coming back to the classic follicular lymphoma, though most of these have all the features, including the genotypic features of follicular lymphoma, that is the 14-18 translocation involving the BCL2 gene, the defining feature of this is not the genetics, but it is morphology. Very few, a small percentage of this still do not have the BCL2 translocation, and morphologically it is not possible to distinguish those which don't have a BCL2 translocation from those which do have a BCL2 translocation. And again, as I said earlier, subclassifying this into grade 1, 2, and grade 3A is optional. And the way if one chooses to do, would be like the cutoff being 15 centroblasts per hypover field as per the revised 4th edition classification. In all these categories, the proportion of cases with BCL2 translocation becomes much lesser. In follicular lymphoma grade 3B, again, the proportion of cases with BCL2 rearrangement is fewer. The proportion with BCL6 rearrangement is much higher. And the same is true of follicular lymphoma with unusual cytologic features. But again, we are not mandating that FISH studies should be done. It is optional to do FISH studies in these cases, with the exception that there are some cases of follicular large B-cell lymphoma, or even the follicular lymphoma with unusual cytologic features, where the follicular lymphoma cells uniformly express MUM1. When one sees strong MUM1 expression in the neoplastic cells, it is important to do FISH studies, and also do FISH studies for IRF4, because you have large B-cell lymphoma with IRF4 rearrangement, which can have follicular patterns, and to exclude that entity. Then when we come to this entity of follicular lymphoma with predominant diffuse growth pattern, here most of them do not have 14-18 translocation, and they have a STAT6 mutation or 1p36 deletion. Recognizing this entity may be of some clinical relevance because the biology is a bit different. They remain localized. Predominantly. They present predominantly in inguinal areas. They often express CD23. So this seems to have a different biology to the classic follicular lymphoma. When we look at these BCL2 negative, rearrangement negative follicular lymphoma, there are some unique features. One of the features is STAT6 mutation is far more frequent in the BCL2 rearrangement negative follicular lymphoma. There are also other differences, like KM2DD mutation is far more frequent in classic follicular lymphoma as compared to BCL2 rearranged follicular lymphoma. Then you can see a Notch2 mutation is a characteristic feature of nodal marginal zone lymphoma. Then you have the MAP2K1 mutation is characteristic of pediatric type follicular lymphoma. So mutation studies, whenever the follicular lymphoma is not typical, is not classic follicular lymphoma, undertaking FISH studies and mutation studies may have value. The next question that comes up is our concepts of follicular lymphoma maybe can be quite simplistic. If you look at it, germinal center, you have the centroblast, you have the centrocytes, and again, all follicle center cells cannot just be categorized as dark zone cells and light zone cells because they keep transiting between dark zone and light zone. They come back into the light zone, and there are various sub-stages within their transit from dark zone to light zone to their eventual coming out of the germinal center. So can we find the ontogenic relationships of different types of follicular lymphomas to different stages of B cell maturation within the germinal center? That's a question that needs to be addressed in future classifications. Here are a few examples of these different types of follicular. One of these is a follicular lymphoma with diffuse growth pattern. You can see, as the name indicates, it's got a diffuse growth pattern. You can see some remnant follicles or microfollicles, which can be BCL2 positive or negative, and CD23 is often positive in these cases. Then here is the follicular lymphoma with unusual cytologic features, where the morphological features of these cells in this particular case is more like large centrocytes, and classifying the cells as centrocytes and centroblasts becomes extremely difficult. There are some changes in lymphoplasmacytic lymphoma. We now recognize that there is, we broadly classify them as Waldenstrom type LPL or non-Waldenstrom type LPL. And within the non-Waldenstrom type LPL, there is IgG or IgA LPL, and non-secretory LPL without bone marrow involvement, but primarily presenting in tissues. There are large numbers of large B-cell lymphoma. I'm not going to go to each of these categories. This is, probably worth for an entire workshop can be dedicated to large B-cell lymphomas, but I'll touch on some aspects which have changed from the previous edition. Key changes include recognition of changes to the what used to be called the double hit or the triple hit lymphomas. There are some changes. Now we recognize that the diffuse large B-cell lymphoma, high-grade B-cell lymphoma with MYC and BCL2 rearrangement is a distinct entity. But those which had MYC and BCL2 rearrangement have been taken away from this entity. So you can have a diffuse large B-cell lymphoma with MYC and BCL6 rearrangement. So this would come under the category of diffuse large B-cell lymphoma, NOS. Similarly, you can have a high-grade B-cell lymphoma with MYC and BCL6 rearrangement. This would be categorized as high-grade B-cell lymphoma, NOS. So the double hit category is a much more constricted definition, is much more focused definition, and it should have both MYC and BCL2 rearrangement. It's also recognized that these lymphomas morphologically can have features of a diffuse large B-cell lymphoma. So the changes made in the name incorporate that it could either be diffuse large B-cell lymphoma or high-grade B-cell lymphoma morphology. And also in practical terms, it helps diagnostic pathologists who might have called an entity as diffuse large B-cell lymphoma based on morphology, but later the FISH results show a double hit. So it won't be a major alteration in the diagnosis, but a refinement of the diagnosis from a diffuse large B-cell lymphoma to a double hit lymphoma. Then what used to be called a Burkitt-like lymphoma with 11q aberration is now relabeled as high-grade B-cell lymphoma with 11q aberration to acknowledge that there is nothing in common with Burkitt lymphoma. And Burkitt lymphoma is a pure entity with immunoglobulin MYC translocation. Then we have entities of fibrin-associated large B-cell lymphoma, fluid overload-associated large B-cell lymphoma, and we have primary large B-cell lymphoma of immune-privileged sites, which we will come in a minute. First, about the double-hit lymphoma of MYC and BCL2 rearrangement. As I said earlier, you can have morphology is not always similar in these. You can have Burkitt lymphoma-like morphology. You can have a blastoid morphology, as in the upper panel here, or you can have a morphology which is very similar to diffuse large B-cell lymphoma morphology. So morphologic heterogeneity exists within this double-hit lymphoma. And there have been many studies. We have gone through several studies, and we have struggled to see the uniqueness of what used to be called double hit or triple hit lymphomas, and why, and the question about whether MYC BCL6 translocation lymphoma should be included under this category or not. Recently, we had a publication from multi-institutional study which we did in the UK, which looked at this question. They looked at more than 100 cases of aggressive lymphomas with MYC rearrangement. And the question here, the survival graphs, what it shows is you have a diffuse large B-cell lymphoma with the double hit as per the WHO classification, where MYC and BCL2 is rearranged, that's in red. And then you have here MYC BCL6 rearranged, which is in green, and single hit, only MYC rearranged DLBCLs in blue. And you can see that there is no survival difference between diffuse large B-cell lymphoma with MYC rearrangement and diffuse large B-cell lymphoma with MYC and BCL6 rearrangement. The earlier studies which looked at aggressive B-cell lymphomas with MYC and BCL6 rearrangement tend to correlate the survival with all DLBCLs. But that was not the right way to compare the survival. MYC BCL6 rearranged lymphomas should be compared with diffuse large B-cell lymphoma with MYC rearrangement, as we did in this study, and there is no difference in survival. As against that, if we look at MYC BCL2 rearranged lymphomas, they have a poor survival, thereby substantiating something that the concept that we have brought in the WHO classification, that MYC BCL6 rearranged lymphomas should be taken out of the category of the double hit lymphomas. Then the other change which we brought about was the primary large B-cell lymphoma of immune-privileged sites. So this includes lymphomas, primary lymphomas of the CNS, vitreoretinal areas, and testis. And it's important to make sure that these patients are all immune competent. If they are immune deficient, it goes into a different category, which we will come later. So these are predominantly adult patients with these lymphomas have very aggressive behavior. And the vitreoretinal lymphomas are often bilateral and often occur concurrently with CNS involvement. And testicular lymphomas can relapse with in the contralateral testis or in the CNS side. They typically are non-GC subtype, and they typically carry MYD88 and CD79B mutations. And they often have genetic inactivation of the MHC class 1 and class 2 and beta 2 microglobulin with subsequent loss of MHC class 2 protein, and thereby allowing them to evade the host immune system. Then we have fibrin-associated large B-cell lymphoma. Here, they typically do not form a mass. They're typically small lesions which are discovered incidentally. It's important to know about this entity because this is a very indolent malignancy or indolent neoplasm and should not be treated aggressively. They have excellent outcomes, and in most cases, surgical excision itself is sufficient. They are always associated with EBV. They also have a non-germinal center phenotype. And it is thought that the local fibrinous environment creates a hypoxic environment and facilitates the cells or the tumors, neoplastic cells to escape the host immune system. Here is an example with a patient who presented with a large adrenal cyst. and it looked like a hemorrhagic cyst, but part of the cyst wall showed an abnormal infiltrate, which you can see these are all large lymphoid cells within the fibrin mesh, and these were CD20 positive, EBV positive, MUM1 positive with a very high Ki67 expression, but all that was required for this patient was excision of the cyst. Then you have an entity called fluid overload associated large B-cell lymphoma. Again, this has to happen in an immune competent setting. Often these patients are elderly, so the question might come, oh, can these patients be, can an immune senescence play a part of role? So that's again a challenging question. How do we address immune senescence? Is a difficult area. Often these patients have many other problems, like fluid overload from chronic heart failure or kidney or liver failure. They're present with unilateral or bilateral effusions on main wall, pleura, pericardium, or abdominal cavities. There is an association with hepatitis B and C viruses. KSHV is negative, but 1/3 of the patients are EBV positive. So on this aspect, there is a difference between the WHO approach and the other classification coming from the international consensus group, where they have separated, where they don't include cases which are EBV positive. We will have to see how the evidence evolves, whether the EBV positive cases will have a different biology. We will have to be open to that as we go towards the next edition of the classification. About 50% of them have MYC translocation, and rarely, there can also be involvement of the BCL2 gene. But it should not be a double hit lymphoma to be accommodated in this classification. Then we come to the high-grade B-cell lymphoma. Sorry, there's an error here. With 11q aberrations. Morphologically, these can resemble Burkitt lymphoma or can sometimes have a large cell lymphoma pattern. But a typical appearance is a starry sky pattern with abundant debris and a large number of tingible body macrophages. The characteristic cytogenetic abnormality is in the area of 11q, where you have centromeric gains and losses in the 11q24 area, and the loss being much more specific. The molecular profile of this is closer to diffuse large B-cell lymphoma than to Burkitt lymphoma. Here's an example of two of the cases that we have seen, which shows again the morphology can be a bit heterogeneous. Here is a case which has some of the features of Burkitt lymphoma. Here's a case which looks much more like a diffuse large B-cell lymphoma, and both of them had the characteristic. These are BCL2 protein, they are CD10 positive, BCL2 expression is negative, but there is no MYC translocation, and they have the characteristic 11q abnormalities. Then we have the high-grade B-cell lymphoma, not otherwise specified, which is an aggressive B-cell lymphoma composed of medium-sized blastoid cells. So the definition of this entity is morphological. If the cells should not be large, they have to be medium-sized or blastoid cells. But again, this is not reproducible. In a large multi-institutional study in the US where we tried to look at reproducibility, it was not very reproducible. So, but morphologically, it can have blastoid features, or it can have Burkitt-like features. And then the profile of this is predominantly germinal center B-cell profile, CD10 positive. TDT can also be expressed in some of these cases. EBV association is quite rare. In less than 10% cases, one would see. You can have single MYC rearrangement in about 30% cases. You can have BCL2 or BCL6 rearrangements in a minority of cases. You can have MYC and BCL6 rearrangement. The only thing it should not have is it should not have a MYC and BCL2 rearrangement. It can still have a double hit signature. When we say double hit signature, we are talking about the RNA expression, and that can be similar to a double hit lymphoma, but without having a double hit genotype, that is MYC and BCL2 translocation, should not be present for a diagnosis of this entity. So we looked at a large number of high-grade B-cell lymphoma NOS in the US, and as you can see here, we didn't see any significant differences based on morphology. Again, when we tried to do an inter-observer study, which was not reproducible, but you can see there is some survival a disadvantage for the blastide variant, but it is not statistically significant. But what is very clear is these patients, those who have TP53 mutations, alterations, they tend to do badly, and patients who are on R-CHOP do badly as compared to those who are given dose-adjusted or EPOC. So there is a clinical relevance of making this diagnosis correctly, because these patients require to be treated much more aggressively with dose-adjusted or EPOC. So these are the changes that have happened in the large B-cell lymphoma. What used to be called primary DLBCL of CNS, now if it occurs in an immune deficiency setting, it goes under the into IDD LPDs, which we will talk about. But if it is not in an immune deficiency setting, it would be classified as large B-cell lymphoma of immune privileged sites. Diffuse large B-cell lymphoma, NOS, many of them may remain as diffuse large B-cell lymphoma, NOS, but based on the site, if it is in testis or vitreoretinal site, it would go into the category of large B-cell lymphoma of immune privileged sites. If there is any IDD setting, it would go into the IDD lymphomas. High-grade B-cell lymphoma, what used to be called double hit or triple hit, some of them which do not carry a MYC BCL2 translocation, even if they have MYC BCL6 translocation, it would end up as a diffuse large B-cell lymphoma or as a high-grade B-cell lymphoma, NOS. And then you have those which are BCL2 MYC rearranged cases. They would end up as a MYC, MYC and BCL2 rearranged diffuse large B-cell lymphoma or high-grade B-cell lymphoma. Then we didn't. I'm not going to discuss this. What used to be called the gray zone lymphoma of diffuse large B-cell and classic Hodgkin lymphoma. Most of them would remain as mediastinal gray zone lymphoma. A change in the name, minor modification in the name. We brought down the long name into a shorter name in the new classification. Some of them may not have all the characteristics, and some of them which are primary extreme mediastinal would go into diffuse large B-cell lymphoma, NOS. Again, it's important to look at the MYC BCL6 and BCL2 rearrangement analysis is very important to categorize these cases. And in some cases, when doing 11Q analysis is also extremely important to come to the right diagnosis. We move into immune deficiency lymphoid proliferations. And so we have tried to bring together, in the earlier classification, they were subtyped based on the type of immune deficiency. Like you had the post-transplant lymphoproliferative disorders, you had HIV-associated lymphoproliferative disorders and lymphomas. But we have tried to understand that there's a common thread across all these immune deficiency and dysregulation settings. And there's a common theme in the morphology that comes up in these entities. So we're trying to bring them together. And so we understand that there is a histological categorization that is possible when we look at the morphology of these cases. They can be, and it can vary from hyperplasia to full-blown lymphomas, and there can be intermediate morphologic groups, which includes polymorphic lymphoproliferative disorder, mucocutaneous ulcer, and then of course you have full-blown lymphoma. And within the full-blown lymphomas, you have got some lymphomas which are unique for an immune deficiency setting, like plasmablastic lymphoma, primary effusion lymphoma. And there are some other lymphomas which are not unique for an immune deficiency setting, like the Burkitt lymphoma, diffuse large B-cell lymphoma, or various other lymphomas. So there's a histologic counterpart for this. Then there is a counterpart which is seen with this, which is the viral association. There can be a significant proportion of these are associated with oncogenic viruses, EBV or KHSV-HHV8. And then you have the setting in which the lymphoid proliferation or lymphoma occurs, which can be an inborn error of immunity, can be HIV, it can be post-transplant setting, solid or hematopoietic stem cell transplant, autoimmune disease, iatrogenic or therapy-related, and then finally immune senescence, which one might question, how do we recognize immune senescence? And I think that's something probably, as we go forward, we need to focus on this. Here is an example, a colonic polyp in a patient following hematopoietic stem cell transplant. And I'm going to show you two examples just to bring up the issue of how should the diagnostic line look like. Here, so the first part of the diagnosis is the morphology, a polymorphic lymphoproliferative disorder. Second part of the diagnosis is the viral association, EBV positive. And the third part of the diagnosis is the setting, that this is occurring in the setting of a hematopoietic stem cell transplantation. Here is a colonic polyp. As you can see, there are the lamina propria have sort of medium-sized cells, and you can see a range of differentiation in these cells. And very few cells are CD20 positive. CD3 positive cells are present, but it cannot. There are many cells which are CD20 and CD3 negative, as you can see, and these cells are CD79A positive. There is varying degrees of plasmacytic differentiation in these B cells, thereby these for CD79A and CD138 positive, and you can see a large number of EBV positive cells. Though there is no complete suppression of kappa light chain positive plasma cells, there is increased proportion of lambda light chain positive cells, or lambda light chain restriction, and this is a classic example of a polymorphic lymphoproliferative disorder. Here's another example. Again, I want to highlight upon you the diagnostic terminology here. Here, the morphology of this case is an extranodal. It is a bone marrow. It's an extranodal NKT cell lymphoma. Here it's EBV positive, and this is occurring in the setting of a post-solid organ transplantation, and it is accompanied by hemophagocytic lymphohistiocytosis. So here is the bone marrow aspirate. You can see atypical lymphoid cells, and then you can also see here erythrophagocytosis, and here is hemophagocytosis, and some more erythrophagocytosis. There is a prominent hemophagocytosis along with presence of atypical lymphoid cells. And here's a co-biopsy, and you can see lymphoid cells, atypical lymphoid cells in the background, and these are CD3 positive, and you can see PAX5 is almost negative, and these CD3 positive cells are EBV positive, and they are cytotoxic T cells. They are CD3 positive, CD8, CD5 positive, and CD7 mostly negative. And here you can see they express TCR beta. CD56 was negative, so they express TCR beta, thereby we call it TNK cell lymphoma, but it's a T cell subtype, CD8 positive cytotoxic T cell subtype of TNK cell lymphoma. And so it expresses T cell TIA1, which is a cytotoxic molecule, along with TCR beta. And you can see PAX5 is negative, CD20 is negative, and occurring in the background of hemophagocytic lymphohistiocytosis. So just to summarize the changes that we are seeing in the fifth edition of the WHO classification, before we go that, in the earlier edition, these were classified by the type of the immune suppression setting, like you have the post-transplant setting, the HIV setting, other iatrogenic LPDs, and then LPDs occurring with primary immune disorders. So that was the way we used to classify earlier. In the new classification, we have tried to understand that there is morphologic commonality between all these entities. There is viral commonality between all these entities. So we try to come together with a classification which recognizes the morphologic overlap between these groups, but also brings up the differences in setting, and it brings up the differences in the viral association. Am I beyond my time?
Sir, please go ahead, sir.
The other changes that have come of introduction of new entities in the plasma cell area, which is one is cold agglutinin disease, and the definition of this is that patient should not have any known lymphoma. And we have monoclonal gammopathy of renal significance, where biochemically it would look like an MGUS, but patient has renal disease and it would necessitate treatment. And then you have ASOP, which is adenopathy and extensive skin patch overlying a plasmacytoma. These are some of the new entities which have been introduced. I will quickly move into some areas of the T-cell lymphomas before I conclude. There are some new terminologies that have come in the T-cell lymphomas. Again, this doesn't stand out as a main entry. Here, the primary mucosal CD30 positive TLPD, which comes as a subtype within the CD30 positive in the cutaneous chapter. So, but we now recognize like the lymphomatoid papillosis and CD30 positive LPDs, you can get very similar occurring lesions in the mucosal sites, and that need to be recognized. And then similar to the indolent TLPDs occurring in the GI tract, you can also have NK LPDs that's being recognized. And then we recognize EBV positive nodal TNK cell lymphoma, which is far more aggressive than the extranodal EBV positive NK T cell lymphoma. So these are the three significant changes that you see. I want to also talk a little bit about T prolymphocytic leukemia, and though the terminology has not changed, the diagnostic criteria has changed. In the earlier criteria, one would accommodate cases which lacked rearrangement of TCL1A family of genes, but now TPLL is defined not only by the immunophenotype, the lymphocyte count, the clonality, but it is required to have rearrangement of TCL1A family of genes, or it should have the protein expression equivalent of that, that is overexpression of TCL1A protein, to be classified as TPLL. This was not a requirement in the earlier classifications. Ideally, one should do a FISH analysis to prove this rearrangement. But even if you do by immunohistochemistry, if you can show that TCL1A is overexpressed, that would be good enough for a diagnosis. This is a classic example where the peripheral blood showed nucleolated circulating cells, and you can see here this was the bone marrow, which was showing an infiltrate with these kind of monomorphic infiltrate of these cells, which was CD3 positive, TCL1 positive, and double expressor for CD4 and CD8. And you can see here that there was a break in TCL1, but when we looked at the cytogenetics of this, it was not involving TCR alpha or delta location. And when we looked at TCR beta, this was an unusual rearrangement which resulted in TCL1 being co-located with TCR beta. So, but we got to prove either the translocation involving TCL1 locus or expression of TCL1 protein to classify a case as TPLL. Because there are, if one were not to use a restrictive classification, one could be including other aggressive leukemic types of mature T-cell lymphomas in this category. And most of, in the recent times, I have seen cases which can be strongly GATA3 positive, which can be mistaken for TPLL. So there is a question, again, this is not proven, a lot more studies are required to be done, whether some peripheral T-cell lymphoma NOS can present in a leukemic form and can have morphologic overlap with T proliferatic leukemia. But studies are required, larger cohorts are required to look at this. There are some minor changes in T large granular lymphocytic leukemia. We now recognize that there are three types of this. One, the classic one is the CD8 type. Then you can have a CD4 type, and then you can have gamma delta type. The CD8 type, which is the most typical one, has STAT3 mutation. There is an overrepresentation of STAT5B mutation in the CD4 positive type. Again, if you look at it, this is a fairly common disease, and you can see how we have tried to balance between essential and desirable criteria here. Usually, like in most institutions in the West, to make a diagnosis of TLGL, not only one would look at the immunophenotype, the counts, but one would always do, along with clonality, one would always do mutation studies. But in many places where this is not an uncommon disease, it is not always possible to do clonality or to do mutation studies. So in the essential criteria, we have said presence of at least 2 of the 3 essential criteria, and with one desirable case sufficient for making a diagnosis. So if one was not doing clonality or mutation studies, if there is a long-standing cytotoxic cell identifiable population where you has a typical immunophenotype and has a typical bone marrow morphology on a core biopsy, one could call it TLGL. But ideally, if one is not doing bone marrow biopsy, if one is only doing on peripheral blood, I think they should do clonality studies, document either it is monoclonal or oligoclonal. But in most of these Western settings, one would do clonality, core biopsy, and mutation, and follow up to show that it's the same clone that persists over a period of time. So there is a bit of balancing between essential and desirable criteria, taking into consideration that the WHO classification should be made applicable across the world. This is a new entity, the indolent NK cell LPD of the GI tract. This was formerly known as lymphomatoid gastropathy or NK cell enteropathy, and was thought to be a reactive process. But now we have recognized that there is recurrent JAK3 mutations in this group, and so this is a clonal process, and it is neoplastic. Usually, these patients have a very benign outcome. There can be spontaneous regressions, there can be recurrences, but no transformation occurs to a full-blown lymphoma. So it's a very indolent disease. On aplastic large cell lymphoma, there are not too many changes from the previous ones. We still consider ALK positive ALCL, ALK negative ALCL, and breast implant associated ALCL. There was some discussion about whether we should formally try to make subtypes of ALK negative ALCL, like the DUS22 rearrange, the TP63 rearrange, and others. But I think we need to look for more confirmative evidence. But we know TP63 rearrangement can occur in some of the ALK positive ALCLs, or sometimes occur with DUS22 ALCLs. And we also know DUS22 rearrangement can occur in primary cutaneous ALCL. So at the moment, we have kept ALK negative ALCL. We have not further subdivided ALK negative ALCL. But this is an area which I think we have to keep watching of how things evolve. Just to show you an example, we recognize that there are cases of ALCLs which resemble Hodgkin lymphoma, which has many Hodgkin lymphoma features, and a subset of this carry rearrangements of JAK2. And it's important to recognize this because these patients may respond to JAK2 inhibitors. This is one of our cases that I've seen here. You can see cells which have some of the morphologic features of mononuclear Hodgkin cells. These were CD30 positive. They were also positive for, but unlike a usual Hodgkin lymphoma, you can see they are CD45 positive, they're CD4 positive, some of them are CD25 positive. PDL1 was not uniformly positive. Most classic Hodgkin lymphomas, you see uniform positivity of PDL1, whereas this was positive only in a subset of cells. And on flow also, we could recognize the CD30 positive cells, but these CD30 positive cells were negative for CD40. That was something which was different from what one would see with Hodgkin lymphoma. And they also had low-level expression of CD5 and CD15, and CD4 was also dimly expressed. Then we employed a technique. Then we went on to do clonality studies in this case, and we could not prove that there was any clonal rearrangement. We did our conventional NGS gene capture. We could not recognize any mutation in this sample. Then we went on to a technique called RNA sequencing for fusion plex to specifically look for any fusion genes. And this case showed caprin 1 JAK2 fusion, which is one of the fusions of JAK2 described in this entity, newly evolving entity. Again, this doesn't find a specific, it doesn't come up as a specific subtype in the WHO classification, but this is a space that we need to watch as we evolve, because this could have prognostic and predictive connotation, and these patients may respond to JAK2 inhibitors. Then there are, again, many subtle changes in nomenclature and our approach in nodal T follicular helper cell lymphomas. One important thing is to bring all these entities under one umbrella, nodal T follicular helper cell lymphoma, and then subdivide them into angioblastic type, follicular type, and in not otherwise specified type. Typically, the workup should involve these 5 markers for TFH cells. One is the PD1, and when one is using PD1, only strong expression should be taken as sufficient evidence to call it TFH, and at least 2 of these markers should be positive. PD1 and ICOS are the most sensitive markers, but least specific. And BCL6 is also fairly sensitive, but not as specific, whereas CD10 and CXCL13 are not sensitive, but very specific markers for TFH lineage. Within the angioimmunoblastic type of nodal TFH lymphoma, we recognize that there are 4 patterns. Actually, pattern 1 is where the architecture is preserved and involvement is partial with a lot of reactive follicles. Pattern 2, where architecture is effaced, but you can still see residual follicles. Pattern 3 is the one which is the characteristic features are present, and then you have a tumor cell rich variant. The nodal TFH lymphoma of follicular type can be quite difficult. It can look like a follicular lymphoma. It can look like a progressive transformation of germinal centers. And if one doesn't pay attention to the number of T cells within these follicles or large nodules, one can miss this diagnosis. Again, we have tried to fine-tune the essential and desirable criteria of the angioimmunoblastic T-cell lymphoma, depending on the patterns. With pattern 2 and pattern 3, I think morphology and immunophenotype is probably sufficient to come to a definitive diagnosis. A requirement of more than 2 TFH markers comes under the desirable criteria. Similarly, clonality and mutation studies of IDH2 and ROA comes to the desirable criteria in when you have pattern 2 and pattern 3 are a tumor cell rich variant of angioimmunoblastic T-cell lymphoma. But when we go to the pattern 1, where there is partial involvement, one has to be very careful. You need more than 2 TFH marker expression, including strong PD1 expression, and you have to do molecular workup, show that there is a clonal T-cell expansion, show that there is mutations in ROA or IDH2 to come to a diagnosis of angioimmunoblastic T-cell lymphoma. Then a few words on, again, this is an evolving space. The molecular subgroups of peripheral T-cell lymphoma not otherwise specified. We know by gene expression there are 2 major subsets in this. One is the TH1 subset, or what we know as the TBX21 type of subset of PTCL, and then you have the TH2 subset or the GATA3 subset, and this has prognostic implications. The GATA3 subset is far more aggressive with worse survival as compared to the TBX21 subset. And then there is an unclassifiable subset. It's also much of the work from Catalina Amador has now shown that you could use an immunohistochemistry-based algorithm using TBX21, CXCR3, GATA3, and CXCR4 antibodies, you can classify PTCL NOS into TBX21 and the GATA3 subset, but you will still have a small minority which is not classifiable. But we have not formally introduced this as a subtype within the WHO classification, but in the fourth, with increasing evidence. As I said earlier, evidence from one group is not sufficient to come as an entity or a sub-entity in the WHO classification. We need validating evidence from other groups to accommodate that in the WHO classification. Then the other entity which has come up is the EBV positive. Within the EBV positive NK T cell lymphomas is a nodal subtype as distinct from the extranodal subtype. So primarily here, primary involvement is in the lymph node, but can go on to involve extranodal sites. These patients present with advanced clinical stages. They have B symptoms. Morphology looks more like a large cell lymphoma, and there's a greater preponderance of T cells, cytotoxic T cell phenotype here than the NK cell types. Like 80% of them are cytotoxic T cell lineage. And the mutation pattern in this is different. More than 60% of them have TET2 mutations. The conventional extranodal NK T cell lymphoma, 80% of them are the typical nasal ones. Rest of them can be seen in skin, GIT, testis, and other places. And here, they have a characteristic angiocentric pattern with necrosis. Most of them are NK cell lineage rather than T cell lineage. And the mutational pattern of this is different from that of the nodal type. And the nodal survival of patients with nodal type is quite dismal as compared to those of the extranodal type, where survival can go on for years. Here is an example of an extranodal one, but of the T cell lineage, having many of the features what one would assign for a nodal type. Here you can see much more monomorphic. There are no other inflammatory cells, very little inflammatory cells in the background. The tumor cell rich variant, CD3 positive, 2 positive, and TCR beta positive. And CD56 in this case was negative, but can be positive. But once you see expression of TCR beta, TCR delta, that means it is a T cell lineage tumor. And CD8 positive, Granzambi positive, and you can see Ki67 expressed in almost all the cells. And by definition, these lymphomas are EBV positive. I think this should be my last slide. Thank you very much. I think I went beyond my time, but yeah.
Thank you, sir, for the fantastic update. It was wonderful, superb, fantastic. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Naresh Kekari. Yes.
Thank you so much, sir. It was an excellent learning for all of us. I have a question with respect to the DLBCLs. A lot of work has been done in DLBCLs where you have different subsites, MCD. So you've not touched anything on all of that. So
yeah, when DLBCL, that would be a separately that would be an entire lecture on its own. I think the genomic subsets which have come from the Stouts group, they're all extremely relevant. And I think one should be evolving into doing not just the mutation studies, but also all the other studies that is required to come up a combination of mutations, gene expression, copy number changes, I think should be brought in DLBCL. Because unless you do all of them, not just mutations, you can't come into the genomic subsets of DLBCL. And what is required today is that we develop the evidence base that is necessary for the next classification. So I can't stress it more. I'm in US again. Many things are dictated by what insurance companies would pay and not pay. But I think the more and more evidence that we have, and in many cases that we still do it. like in almost all T-cell lymphomas now, because we know that these mutations are useful for diagnosis, we tend to do. In DLBCLs, again, once we come to like MYD88 is crucial for MY, like there are many categories which are decided by 79B mutations and MYD88 mutations. So that becomes a necessity. As of now, for every DLBCL, doing MYC translocation, and if MYC translocation is positive, the reflex test to do BCL2 and BCL6 is accepted by everyone. Everybody will do. EBV association, every case goes through that. But beyond that, how uniformly we will do all the genomic tests and transcriptomic tests, I think to bring that as in a uniform way, we probably require more evidence. And I think we will go through a phase where it is done in a proportion of cases and not done in every case. And I'm almost certain the path in which we are going, it will become an uniform test in at least in places where it is affordable. Because the big question about this is affordability. I don't think not many people will dispute the scientific and clinical relevance of this. There are some areas one may dispute that as well, but I think the big question is affordability.
Yeah, because 17 entities in such, and whether you can combine together and have a more uniform genomic classification in that way is what.
Yeah, but still, I don't think some of the entities which are decided by immune status, decided by location, I don't think, like a fibrin-associated large B-cell lymphoma, even if it has many other genomic, attributes, it would still respond very well to just surgical intervention. So there, the site of involvement is, so the contribution of each of these attributes, whether it comes from clinical, whether it comes from a viral association or the immune status, or it's the genomics of the tumor, or even the microenvironment. Like I did not talk anything about Hodgkin lymphoma or T-cell rich B-cell lymphoma. The microenvironment is so important. So each of these, so in which case what contributes, I think is different. And I think we have to look at it in a holistic manner.
Thank you.
Thank you.
Thank you, sir. Yes, ma'am, please go ahead.
Would WHO want to talk about or address the issue of practical issue of having to evaluate limited tissue material? And probably in this group of disorders, it is the greatest challenge. And I think, I don't know if I can generalize, but that seems to be the favored approach for lymph nodal or tissue evaluation as far as the clinicians are concerned. Would WHO want to address that at all?
It's a difficult area. We know what is optimal, but then there is an issue about what is practical. And some of these things, some of the changes that have happened over a period of time is not even based on practicability. It is just based on without good reason. Like I can understand a deep-seated lesion, needle core being practical, but when you have a superficial lymph node, where a lymph node biopsy can be done as an outpatient procedure, but people tend to do, and it's the same thing all over the world. It's not anything specific about India. It happens everywhere. So WHO itself, I don't think is going to address that. But what's happening is we're also coming up with several reviews. We just finished a set of reviews for modern pathology. And in modern pathology, the reviews, we have tried to focus on how it would impinge on practice in North America. Subsequent, after once we finish this, we'll be coming up with a set of reviews in Journal of Clinical Pathology. And in the reviews in Journal of Clinical Pathology, what we are envisaging is we will try to address issues about practice across the world. So taking into issue about, how do we develop algorithm? How do we, when the resources are limited, how do we apply WHO classification. We were not particularly thinking about addressing needle core versus excision, because that is something not limited to develop, in a resource limitation setting. In fact, there may be more resources required to do a needle core, because most of these people will go for imaging guidance, and it may actually turn out to be more expensive than an excisional biopsy. But it still has a relevance, because there are some places like in Africa where it's simply not possible. And so we may address it, but that is still not written yet. But so we may address it to some extent. But that is something what we are facing. And again, we should not legitimize that is the right approach. Like when we wrote national guidance in the UK, we made it quite clear, okay, that these entities require a whole lymph node biopsy. If somebody goes against the national guidance, they're doing at their own risk. So I think what is required in every country is to say, okay, what is optimal, what should be national guidance should be written up. And then if people go against it, don't follow it meticulously, there is an element of risk, however small the risk may be. And again, when we come to needle core biopsies, it depends on so many things come into account. The experience of the person who is doing. And just because at the hands of an experienced person, it is reliable, that is not sufficient. Whatever classification, whatever strategy you come up with, the strategy should be reliable in anybody's hands, in anybody who makes an earnest effort to come to a diagnosis. Not only.
So would WHO want to state that upfront and say these criteria are meant for?
No, we haven't done that. We have said, like, follicular lymphoma, we have said that grading may not be feasible on a needle core biopsy. If we are doing only with a small biopsy, you may just call it classic follicular lymphoma and not go anywhere beyond that. And tell all the problems why we can't. But I think we have to be careful where we, we don't want to promote something as okay, this is the dogma, because the whole thing about any of this is not to be too dogmatic, because no dogma remains. Because we are at the same time we are talking about bringing up a classification which can be made on cell-free DNA. So this is such a rapidly evolving field. Tomorrow, how will the classification look if there's a large element of cell-free DNA component coming in? One might argue, even if you do an excisional lymph node biopsy, it may not show histological transformation, but you may have the telltale evidence of histological transformation if you're looking at cell-free DNA. So I think this is an evolving field which we have to incorporate as we go. And I think in parallel to this, I think we got to bring national guidance. What is optimal?
Thank you, ma'am. So this year, ASH education program, there was a chapter on HLH. And Dr. Ashok Kumar was there from Cincinnati. He was briefing about HLH in pediatric population. And he stressed on an entity known as EBV-induced NK T cell lymphoproliferation. Is this entity different than EBV-induced NK T cell lymphomas? And there is also another entity known as EBV-induced B cell lymphoproliferation of elderly. So that can also cause HLH. The treatment is same as that of CHOP therapy, what we give in EBV positive T NK cell lymphomas. So if you can update us on this, because
in the pediatric, there is an entity, a systemic EBV associated lymphoma. Let me just open from what you are describing, I think he's very likely talking about systemic EBV associated lymphoma. Let me just hold on. I can pull up the. Okay, let me share with you. I think from what you are what I understand from the description you're putting is, okay, can you see my screen now?
Yes.
So systemic EBV positive T-cell lymphoma of childhood, okay. This is the condition, as you can see, the definition of this is that it is associated with hemophagocytic lymphohistiocytosis. It has got a multi-organ, rapidly fatal course. So
Right.
as you can see, somebody presenting in the ASH may not be cognizant of what's coming out in the WHO classification. Well, it exactly fits with this entity. I mean,
So
I couldn't talk about each and every entity. There are, I think, close to 100 entities, you know.
True, sir.
So there are, I have seen examples of this. This is a very aggressive disease.
Absolutely.
Yeah.
Thank you, sir. Dr. Rakhi Kar, ma'am. Question, please. Dr. Rakhi Kar, ma'am.
Yeah, thank you, sir, for an excellent overview. It was really great summing up of what we are expecting in the Blue Book. I have one query and one observation. The query is that, sir, is there any role of doing a P53 IHC on any particular types of lymphoma? And the second thing is related to, like, particularly I find mediastinal biopsies, and these are, as Dr. Gayatri was saying, mostly what we get here is needle core biopsies. And as such, mediastinal lymphoma is sometimes like gray zone. And added to that, when we have the needle core biopsies, there's a lot of crushing at times. So it becomes difficult, especially in that setting. So
Yeah, I've been first taking up with the P53. I tend to do P53 in all cases of CLL and mantle cell lymphoma as an initial screen, even ahead of the mutation stage. All of them also go for TP53 mutation studies, but during my routine workup, I tend to do P53 immunohistochemistry. Of course, one could do P53 immunohistochemistry in other areas. I also tend to do in cases of multiply relapsed aggressive B-cell lymphomas, just to give an indication to the clinician that there may be a mutation. And also, sometimes, you know, if you see overexpression of P53, you could probably suggest that it's worthwhile doing a large mutational panel. But with CLL and mantle cell lymphoma, I think P53 status is very important. So I think there is reason to do. The second thing is about needle course in the mediastinum. Yes, it is a problem. Particularly distinction of sometimes between classic Hodgkin lymphoma and primary mediastinal large B-cell lymphoma. So you got to throw in all that is available in your hand, including doing things like PD-L1, CD23. It can be difficult, but you know, and sometimes you may have to resort to getting a mediastinoscopic or a thoracoscopic biopsy. But those situations are few. In most cases, you can come to a good diagnosis even on the needle core. I mean, that's a situation where I think we have to go all out to make a diagnosis with a limited material.
Absolutely. So that tests your how much you can do it. So we end up taking multiple sections and trying to put up a. Thank you, sir.
Thank you, ma'am. Dr. Sheila, ma'am, your question, please.
Can you see me?
Yes, yes.
Hello.
Yes. Please go ahead, ma'am.
Hi. Hello, Dr. Naresh. Thank you very much for your excellent, lucid, and very informative presentation. We are indeed very proud of you being an Indian trained in India to reach such great heights. And it's entirely by your intellect and hard work that you have reached this. We were so proud to see you in the editorial board of the WHO Heme 5, you know.
Thank you.
I'd also like to thank Dr. Agarwal for including us as discussants, which may be an honor for us too. There are two simple, fast questions I want to ask you, Dr. Naresh. One is about peripheral T cell lymphomas. How often do you, is it possible to diagnose peripheral T cell lymphomas when T cell rearrangement is polyclonal? It's not clonal. But histology and everything is more in favor of PTCL, especially the
Yeah.
AITL.
I mean, AITL by definition can be monoclonal or oligoclonal. But the question when we can't recognize clonality, I'll tell you what I do in my regular way I deal with. I always do look for clonality. If I can't identify a clone, then I look for mutations. And if I have the classic IDH2 or OA mutation, I'm quite happy to call it the T cell lymphoma. The other thing is, most often when we say we do clonality, we often do TCR gamma rearrangement, but there's a small proportion of them which may also require TCR beta rearrangement. So about less than 5% cases which are actually monoclonal may not show up as monoclonal with TCR gamma. So maybe when you do TCR beta, those may come up. The other thing one could also do on flow cytometry is TCRB, C beta analysis. Like the kappa and lambda that we use, we can use C beta 1, C beta 2, or just C beta 1 analysis. And you can show that the, say, CD4, CD10 positive population or any population which has lost any of the antigens, you can gate on those cells and look at the C beta distribution. And like a kappa lambda, if they are not of both types, it would mean that it is monoclonal. It's a surrogate, like what we use in B cells. That's another thing.
Is it possible to diagnose just on basis of IHC and morphology?
Yeah, I think if
even
the classic,
if it is polyclonal.
No, like the WHO classification, it's if it is classical, you can probably the type 3, the morphology 3, the pattern 3, you can come to a diagnosis, but there are mimics that one has to be careful with. The mimics are like Hodgkin lymphoma. You can have a background which looks like angioimmunoblastic. So,
yes.
Yeah. I'm not saying it is. See, it's all, if there is a resource, you have no place where you can do a TCR beta analysis. You have no place where you can do mutation studies. What do you do? So there are practical considerations that one may have to go by. And if all the cells are strongly PD1 positive, along with, say, BCL6 and CD10 expression, if you see outside the follicle in the T cells, I think that's a very useful feature that I almost never see in other conditions.
Okay.
Yeah.
The next thing is about this mutation, this classification based on molecular genetics, which the West is marching ahead with and penalizing the developing countries, as you said earlier. All these things, these mutations which you described are all in the textbook. It doesn't exist in real life for us. So I was wondering whether this could be, there could be a centralized lab in India, run by the government, which does all this molecular genetic work for us at a nominal rate, so that all of us could join that bandwagon.
No, I have, I strongly feel these things can be done at a much cheaper rate in India than what is being done in the West. So I can foresee situations where you will have many people running these tests in India, and maybe in 5 years' time, it is done more frequently in India than in the West. It's quite possible, because the rate at which the prices are going to come down here may not match what may happen in India. In terms of scientific and technical expertise, there are many people in India who are extremely good. Like recently, I know Gaurav from Tata Memorial Center, he is got a huge grant from DBT where he's going to focus on lymphomas.
Okay.
So there are excellent people in India who will start doing this.
But will they do it for us as well at a nominal rate?
If that can happen anywhere, it can only happen in place. In the UK, it is possible something like that to happen. In India, it is possible for that.
Okay. Okay.
I mean,
Thank you very much.
Going back, I don't know, 20 years. We could do at least in some of the things we could do, even immunohistochemistry, we could do in a centralized way in India without passing on, charges to referring institutions way back 20 years back. So I can see that something like that happening in India. I'm not saying, because I do not know the current realities, how things happen in India, but I wouldn't be surprised if it happened in India.
Okay, thank you. Thank you very much.
Thank you, ma'am. Dr. Sanjeev Gupta, sir.
Thank you so much, sir, for this extensive overview of the lymphoma classification. I have two small queries. One is about the indolent T lymphoblastic proliferations that you talked about. How often you see them and whether they create a diagnostic dilemma as far as lymphoblastic lymphoma is concerned. And the second query is about how often you do the flow cytometry on the FNACs of suspected cases of lymphoma.
Okay. I tend to do TDT mainly in the context of Castleman's. I'd use it I do in a Castleman's, I would do TDT. I also do CD123 to look at PTC expansions. So I'm using it more in the situation where I expect it to happen. Very rarely have I come across in a situation where in an unexpected manner. Having said that, initially it was recognized in an unexpected manner. That was the problem. But I think the LMO2 stain, which I said, it is very useful. These proliferation, like if you take a thymoma, like normal thymus thymoma, the lymphoblasts are LMO2 negative. So similarly, indolent T lymphoblastic proliferations are LMO2 negative. What was the second thing you asked? Sorry, I forgot.
The flow cytometry for FNAC-based flow cytometry in lymphoma cases. Is it a standard practice?
I'm in a place where flow is done a lot. So every case, every biopsy which is done, not on fine needle aspirates, so we don't advocate fine needle aspirates much, but every other biopsy, needle core biopsy, excision biopsy for lymph node, everything runs through flow. So I'm in a place where flow is used a lot. Back in the UK, we were not using flow that much. Very rarely we used to use flow. So in most cases of lymphoma diagnosis, flow is not essential to make a diagnosis. There are small areas where I think flow is, like in a marginal zone lymphoma, you may want to have the light chain expression, which can be helpful. Again, by immunohistochemistry and in situ hybridization, many of them you can recognize even in some of the T cell proliferations, like C beta analysis, TCR, that can be helpful. But again, it's a useful thing to have. Like in the place where I have, if you read publications from Jonathan Fromm, he is an excellent flow cytometrist for lymphoid populations. When he says this is Hodgkin lymphoma on flow, I believe him. So it will be, again, it's a very expertise-driven area. Like I know there was a publication from Tata on lymph node flow, which again seems to be very dependable in their hands. Prashant has had a very good publication.
Thank you so much, sir.
Thank you, sir. There are some few questions from the audience, sir.
Sure.
Dr. Anil Kumar Yadav wants to know that how significant is to do a big testing, especially in the case of BPLL.
Tell me again, what testing?
how significant is to go for MYC testing, MYC, MYC,
Okay.
especially in the case of B pro-lymphocytic leukemia?
Yeah, as I said, BPLL, what was described earlier, many of them had MYC abnormalities, including MYC translocations. So one would say, yes, you got to do, because but just because MYC abnormality is there does not make it a Burkitt lymphoma. And currently, as I described, BPLL in the WHO is not an entity. So MYC abnormalities can occur as a secondary abnormality in many other lymphomas, including like in follicular lymphoma. You can get a MYC abnormality at the time of transformation. So many other lymphoma leukemias, you can have MYC abnormality as a secondary abnormality. And currently what we believe is what used to be called BPLL, many of them are kind of progression-related transformed lymphomas with TP53 and MYC abnormalities.
Fantastic, sir. Another question from Dr. Anil Kumar Yadav. Clinically, how significant is to do IGH and deletion 6q in CLL testing by FISH?
IGH FISH, you only do to exclude other things. But IGH mutations is very important to identify the unmutated and the mutated type and the stereotypes. IGH V region mutations. But IGH FISH, you do like you want to, if IGH FISH is negative, like most other B cell lymphomas, like follicular lymphoma, mantle cell lymphoma, all those things have IGH rearrangement, translocation, where the partners are different, CCND1, BCL2, or BCL6. Or sometimes you got some, like the BCL3 translocation can also occur in a subset of lymphomas which resemble CLL. But in a bona fide BCLL, I would expect you would have already excluded all those things. So IGH FISH becomes less relevant once you have excluded all other small B cell lymphomas. But IGH V region mutations has a major role in CLL.
Thank you, sir. Another question from Dr. Babita Sodi. BCL2 and BCL6 both can form double hit lymphoma, or should we require a MYC translocation to prove that it is double hit?
No, you can get even a follicular lymphoma which has got both BCL2 and BCL6 rearrangements. So that is not a double hit. So double hit is a very, what should I say, loose word. What if any cancer has got at least 4 or 5 hits? So double hit is not a true name. We just use it in a colloquial manner. But in that, when we use it in a colloquial manner, in the WHO classification, it specifically means MYC and BCL2. You can have MYC translocation with BCL6, you can have MYC translocation with CCND1. Those are not double hits.
So MYC has to be at the center.
Yeah.
So another question from Dr. Anil Kumar Yadav. In case of anaplastic large cell lymphoma, only ALK testing is sufficient, or should we also go for DUS-P22 or any other marker in all ALCL cases, or any other feature of ALK negative cases for other marker testing is required?
Again, depends on your infrastructure. As far as the classification is concerned, once you have enough proof to say this is ALCL, that means CD30 is uniformly expressed, there is some evidence of T cell expression, T cell lineage. When you have to do ALK to distinguish ALK positive ALCL from ALK negative ALCL. So that satisfies the WHO classification. But if you are in an academic center, you would want to do DUS-22, you would want to do TP63 FISH, but again, not essential by WHO to recognize these as, they are not recognized subtypes. We know they are recognized genetic events in the ALK negative ALCL. And of course, as I showed you a case, it may be more relevant when you have what used to be called triple negative cases. In those cases, to look for novel translocations which may have some therapeutic connotations, like the one which I showed you with JAK2 rearrangement, where you may treat those patients with a JAK2 inhibitor.
Thank you, sir. Another question from Dr. Babita Sodi. She wants to know that in extranodal NK cell lymphoma, we have got nasal type as well as extranodal type. Do we also have bone marrow type?
Bone marrow would be within the extranodal setting, I suppose, unless it is a nasal one, also involving the bone marrow.
True. Another question
And the
from
nodal ones also can involve bone marrow. So bone marrow is more like a disease extension to bone marrow, stage 4 disease.
Absolutely. Another question from Dr. Inmon Tent. How do you diagnose if Reed-Sternberg's like large cells the pathologist has got Reed-Sternberg like large cells with a strong CD30 positive, focal CD15, CD4 positive, TIA1 positive, but negative for PAX5, TCR rearrangement, negative for CD2, CD3, CD20, and CD17 and the pathologist is not able to conclude. And given the differential diagnosis, Hodgkin's versus ALK negative ALCL, how can we go with the treatment of such cases?
Yeah, I mean, the case which I showed you was a perfect example. I think it had all the features what he is describing. CD30 positive, CD4 positive, CD45 was positive. So I look at CD45 very carefully. In classic Hodgkin lymphoma, CD45 is negative. And the thing that made me worried in that case was the expression of CD45, whereas we know that some T cell markers can be expressed in classic Hodgkin lymphoma. When you see PAX5 expression, that particular case was PAX5 negative as well. And I tend to use things like GATA3, I tend to use things like PDL1. I mean, these are more often expressed in classic Hodgkin lymphoma. But in doing all these workup now, I realize that there may be entities like the ALK negative ALCL, which has got the unusual translocations. So that would be a very good case for RNA sequencing, for looking for any unique transcripts. And there is no one single answer for that. I mean, they're uncommon. Like in the last 3 years, I've seen probably 2 cases like that. So it's very uncommon, but when you get an uncommon case like that, you do complete workup and you may hit something that is somebody has described, or you may describe something new. You got to do whatever he is saying, everything has to be done, and probably more than that.
Another question from one of the audience. A 2-year-old child with orbital mass. Morphologically, there is large B-cell cells admixed with also Burkitt-like cells. On flow cytometry, FNAC suggestive of DLBCL. Should we go for 11q testing in such cases?
If there was no MYC translocation and you felt there were some features of Burkitt, and if the germinal center phenotype, you had a lot of tingible body macrophages, a starry sky pattern, that's a perfect setting to look for 11q.
Absolutely, sir. Thank you, sir. Dr. Manu, you have a question?
Thank you. Thank you, Professor Naresh. That was a really nice talk. I always found the lymphoid part of the WHO 5 complicated compared to the myeloid part. Your talk was very nice in terms of delineating certain things. My question, well, I had a couple of questions. One was already answered. I noticed that they had refined the MBL, the CLL, and SLL component, which was seemingly innocent sort of non-neoplastic or pre-neoplastic condition. What was the rationale behind introducing these new entities in MBL and the CLL, SLL?
Are you asking about in MBL pointing out the CLL type and a non-CLL type? Is that what you're asking?
And a subtype with a very low lymphocyte count.
Oh, the low count MBL and the high count MBL. Okay. Yeah. The low count MBL, the reason was these are incidentally discovered, and most of them do not progress into full-blown CLLs. Whereas the high count MBL, many of them progress into CLL. So the classification, once you make a diagnosis of a low count MBL, it tells the clinician you don't need to follow up this patient that closely. That's one thing. And then when you have a non-CLL phenotype MBL, it's very important and to make sure that the patient does not have a lymphoma. If you have a marginal zone type of immunophenotype, irrespective of the count, that's a situation where you have to make sure the patient does not have a lymphoma. So that's why a non-CLL type MBL is important. And a low count, high count is primarily to know how frequently patient needs to be followed up and the likelihood of developing a full-blown CLL.
Thank you very much.
Thank you. Another question from the audience. It's a very peculiar question. 35 years old male who was diagnosed as classical Hodgkin's lymphoma advanced stage received 6 cycles of ABVD chemotherapy, was into complete remission after 6 cycles of ABVD. After 4 years, patient again had the lymph nodes coming up. And these lymph nodes showed it as a case of CLL bar SLL. Can you please explain how this can be possibility in a case of Hodgkin's lymphoma now being converted to CLL by SLL after 4 years? Is this a new thing, or whether it was previously the CLL by SLL and now that was missed?
Yeah, I think one thing is they have to go back to the previous Hodgkin's and see whether the background small lymphoid cells could have been CLL. So one is revisiting the previous case to see whether it was at the time the lymph node had both CLL and SLL. One will have to go back to patient's lymphocyte counts, whether he had any lymphocytosis that was there from some time. And then one can also look at any clonal relationships between the neoplastic cells of Hodgkin cells and the current CLL cells by looking at whether they carry the same immunoglobulin gene rearrangement. One will have to do, but it's also quite possible. There is no reason that a patient who had Hodgkin's develops an independent CLL. That's also a possibility. But in practical sense, the only one thing that I would definitely do is go back to the old slide and see whether there was any CLL in the background of Hodgkin's, and if that was missed, and look at his peripheral blood lymphocyte count, whether he had any lymphocytosis all along.
Thank you, sir. So I finished all the questions from the audience. Yes, ma'am. Please go ahead. Dr. Shubhangi, ma'am. Please, ma'am.
Yeah. Thank you, Dr. Naresh, sir. It's been a long time to see you again. Thanks a lot for comprehensive explanation of this new classification. I have a simple question. Means initially when we were residents, there was a tumor-like conditions in most of the classifications in the WHO book. But after some period, they were deleted most of the time from the most of the classification. So what is the rationale, do you think, now behind including again tumor-like lesions in this classification of the lymphomas and lymphoid proliferations?
Yeah, one was, as you rightly said, the difficulties, practical difficulties people have between tumor-like and tumor conditions, and having knowledge of tumor-like conditions is relevant. Number two is there are some areas where it is becoming a little bit difficult, in the sense we are seeing, like in Castleman's, we are started to see some of them having some mutations. So in ALPS, we know there is a germline variant of ALPS. So there is what do we call as clonal and what do we call non-clonal? That is also becoming like POEM syndrome. You have a clonal population. So there is a genuine biologic overlap in some areas. And then there is also a practical utility of discussing some of these things. And some of them, like, we always knew PTGC, a 5% risk of maybe having nodular LP Hodgkin's. So I thought we should briefly address PTGC. And if you go to immune deficiency LPDs, we always discussed hyperplasias there. Okay, so that one could argue that there is a tumor-like condition. It's not a tumor. So
Sure. Yeah. And do you think some of these will means you have seen cases where there some of these have transformed into overt lymphomas or
In the
progressed?
immune deficiency setting, yes, there have been, we've seen many examples where something was polymorphic LPD and over a period of time becomes a
Yeah.
monomorphic DLBCL. That's, I think, the best example that I can give. But I'm sure, like, I mean, I don't think I've seen that many. I've seen a few cases of ALP. I've seen cases of ALPS which has gone on to become nodular LP Hodgkin's and diffuse large B-cell lymphoma.
Thank you very much. Thanks a
Thank
lot.
you.
Yeah.
Thank you. Raki, ma'am.
Yeah, one more query. Actually, recently we had a case. It was CLL, but there were many large cells which could be pro-lymphocytes or, but they were cyclin D1 scattered positive in that. And I recalled another case we had long back where we called them para-immunoblast. So anyway, we thought it would fit with the progression in a CLL. So any experience about, I mean,
Yeah, I think we were among the first groups which published cyclin D1 expression, or maybe there was one publication before ours. Cyclin D1 expression in the proliferation centers of CLL in a subset of cases. I think in our first work, we thought about 10% of CLL had cases where there was cyclin D1 expression in the lymphoid cells. So that's not uncommon, and that just having cyclin D1 expression in a subset of para-immunoblasts or prolymphocytes, as you're calling, that itself doesn't make it progressed CLL. So progression, histological progression of CLL, you need, as we described, large confluent proliferation centers like 20x field, or proliferation of more than 40%, or more than 2.4 mitosis per proliferation center. So you got to use those parameters, because cyclin D1 expression itself within a subset of cells in the proliferation center, that can happen even in the regular CLL. Yeah.
Thank you, ma'am. Ma'am, you are muted, ma'am.
yeah, thank you, sir. Actually, this case also had high mitosis.
Okay.
So
It would fit for a progressed.
for
Okay.
Thank you, ma'am. Dr. Nikhil, you have a question? Dr. Nikhil?
He's muted. Maybe he's talking, but he's muted.
Fine. So there is one question which came up from the audience. Maybe the last question we'll take. So can we diagnose Waldenstone macroglobulinemia just based on the light chain to be elevated, kappa light chain, if electrophoresis is absolutely normal?
Yeah, if you have a typical morphology, because you've got a light chain type, a non-Waldenstrom LPL, because you're talking about a non-Waldenstrom light chain type of LPL, you can, provided there is a MYD88 mutation, there I would rigorously look for MYD88 mutation presence, because just having only light chains doesn't make it, can be anything else as well, any other plasma cell neoplasm or lymphoid neoplasm, but it should have typical morphology, it should have typical MYD88 mutation should be there, and then not having IgM does not stop you from making a diagnosis of LPL.
No. Because the thing what he raised was the kappa is 150 and lambda is 40 with the altered ratio, kappa lambda ratio. And with hemoglobin of 6. But electrophoresis is negative.
No, but what's the morphology?
So morphology, bone marrow morphology shows lymphoplasmacytic cells.
And mutation has not been done, I suppose.
Not been done. Yes, sir, not been done.
I think I would advise mutation studies before they come to diagnosis.
Thank you, sir. So any other discussion want to ask, any other question to Professor Dr. Naresh Kikri before we come to an end?
Can I ask a question? I'm Brigadier Tathagat Chatterjee. Can I ask a question?
Please, sir, please go ahead. We are waiting for you.
Good evening, Dr. Naresh. Brigadier Tathagat Chatterjee here. Lovely
Good
talk,
evening,
sir.
Tathagat.
Sir, this NK cell lymphoma leukemia is out. And what do we do for a case which is showing diffuse effacement of the lymphoid architecture in a patient 50 years old with generalized lymphadenopathy, bilateral cervical, axillary, and inguinal with B symptoms? The lymph node biopsy shows diffuse effacement by cells which are monomorphic, almost blast-like, with pseudo follicle formation in the cortex, and all the markers are negative except TDT and CD56. And the patient has now presented with pancytopenia. So I go and do a bone marrow aspirate also, and I see the lymphoid cells in the bone marrow aspirate and biopsy. Biopsy is diffusely involved. Focal interstitial involvement are there. And I do my markers there itself. TDT is positive, CD56 is positive, all the B and T markers are negative. In the flow, the CD5 and CD7 is positive. Surface CD3, cyto CD3 are all negative. So knowing fully well that it was a provisional entity in 4th edition and now completely out in 5th edition, what do I tell my physician? I'm actually part of a team where we treat as well as diagnose. So what do I do in a case like this? What do I write? NK cell lymphoma
But in
leukemia?
your,
Yes, sir. Yes.
CD5 expression would be first of all, CD5 expression would be unusual for a NK phenotype. That's something which would be unusual.
But it is not strong.
It's not strong, I see.
Yeah. CD7 is strong. NK cell. So the flow, the population in the flow came in the myeloid blastic population. So am I dealing with an AML with undifferentiated, or is it?
That was what I was thinking. But 34 is negative and probably myeloma.
No,
probably what you are describing is an undifferentiated leukemia, probably with CD56 expression and TDT expression.
Yes.
I'm just thinking probably that may be a good category to put.
So what do I finally write? Because I have to write this report on Monday.
The question you're asking is CD56 expression adequate for defining a NK cell lineage? And we know CD56 expression occurs in so many other cells, including outside of the hematopoietic lineage.
Anti-MPO is positive.
Oh, MPO is positive.
Anti-MPO is positive.
Then it's an AML. Then you have no problem.
Yes. Or is it?
MPO is a lineage defining marker. So you have a lineage defining marker.
What about ETPL, sir, in this case?
No, for ETP, does it fit with all the features of ETP? Where cytoplasmic CD3 is negative, you said.
Yes.
So I don't think it fits with all the features of ETP then.
So this is because I have now rechecked my IHC and flow completely. So that's why.
From what you are saying, it looks more like an AML to me.
Correct. AML with a CD56 with a CD56 positivity.
Yeah.
Okay. It was an interesting case. Thank you. Thank you very much.
Thank you.
Thank you, sir. So we have finished all the questions from the audience, and I think there are no more raising signs. So I may say you were so fantastic, and what a detailed lecture you have given on update on T-cell lymphomas. It was superb and fantastic. You were so easy, and actually the whole subject you made it so easy. If I would have read that subject myself today, I would not have understood. But you have made it so easy and very updated classification. What you said basically, it was so in detail, and it was worth listening to you, sir. Fantastic, great learning from you, sir. And what a wonderful discussion, sir. Thank you so much for being with us today. And you spent almost 3 hours with us. Thank you for giving me so much of time to all of us, sir. Thank you once again, sir, for joining all the discussions. And I thank all the audience to join over here to participate for this 3-year wonderful webinar with Dr. Professor Naresh Kikri. And meet you tomorrow at sharp 11:30 a.m. with another beautiful webinar. Thank you so much, sir, once again.
Thanks
a lot.
Thank you very much. Yeah, pleasure. Bye.